she summarized the past, present, and future of social epidemiology. It's a very interesting article, and I recommend everyone read it. But what struck me was her summary of the challenges in social epidemiology. We are in a field where it is difficult to specify a well-defined treatment. Our field is not like clinical medicine, where we can give a patient a pill and see whether it works or not. Often our treatments are things like education, which is quite complex exposure. And there's also a long causal chain between exposure to social determinant and as a social determinant and health outcomes. For example, when I study income distribution and health, there are many parts to that causal chain, which makes it very difficult to convincingly establish causality. And obviously, larger structural interventions like changing the distribution of income are not usually feasible to evaluate with randomized controlled trials. So we have some major challenges in the field. And so I'm going to give you lead with an example of workplace health equity. Causal inference in studies of health equity in the workplace can be challenging because of what we call endogeneity bias. What does that mean? So suppose we find that there's an association between having a nice work environment and good health. Suppose we find that. That doesn't necessarily mean that the relationship is causal. Why? The reason is because many employers, like Google, try to recruit the most capable and healthy employees by offering more and more attractive working conditions. They have to offer free lunch and massages and so forth. And in addition, many workers also keep interviewing at different places until they find a job that is the most attractive for them. And obviously, healthy employees can afford to spend the longest time engaging in the job search to find their dream job. And by contrast, if you're less healthy, many workers they're forced to take what job is available. And the result is that healthy workplaces attract healthy workers. And that's a problem for causal inference, because suppose I have a factory. If I offer attractive amenities like Google does, it doesn't mean that my workers will become healthy. It's just we're simply observing this process of selection and endogeneity. So I'm going to introduce through a series of examples the kinds of studies that my colleagues have been doing to advance our understanding of health equity. I think one solution to endogeneity is to look for natural experiments. If we can't do a randomized trial, then can we observe a workplace where they change their policies, and then we can observe what happened to the health of workers before and after the change. So the first study I'd like to introduce is about night work and musculoskeletal symptoms, musculoskeletal pain. And this study was led by Dr. Hae-Yoon Lee, who spent some years in my laboratory. And as she points out in this article, night work is a risk factor for a variety of health problems, not just sleep disturbance, but also musculoskeletal disorders and even cardiovascular disease. And indeed, in South Korea, work-related musculoskeletal disorder, mainly pain, accounts for about 70% of compensated occupational diseases. So it's a major problem and a source of health inequity between day workers and shift workers. And so she posed a question: can we improve musculoskeletal pain among workers by eliminating night shift? Now, she could have done this through an observational study, but instead she was able to find a quasi-experiment. namely in 2010, the Duwon Precision Industry company, which is an automobile engine pump manufacturer, they decided to eliminate the night shift, the shift from midnight to 8:30 a.m. after negotiations with the labor union. It's a thing they did. And because she had information on musculoskeletal pain before and after the change in policy, she was able to conduct what we call a difference in difference estimation to compare the prevalence of pain among shift workers and non-shift workers before and after the introduction of the new system. So this is a quasi-experiment. It's a bit like a trial, except the assignment to treatment is not random. And this depicts the general form of a difference in difference analysis. We have time on the horizontal axis, divided into the period before the introduction of the new system and after the introduction. And on the vertical axis, we have the prevalence of pain reported by shift workers and non-shift workers. So the control group is the non-shift worker, and the treatment group are the workers who used to engage in night work before the intervention shown in the dotted bar here. And what we are trying to estimate is whether there's a drop in the prevalence of pain as a result of eliminating the night shift. And that effective treatment shown here is what we call the difference in difference. The first difference is in the dimension of time, before and after, and the second difference is between night shift workers and ordinary day shift workers. So it's a difference in difference. So here's what the difference in difference estimates look like. We can see that with regard to shoulder pain, among treated, namely that's workers who used to do the night shift, before the change in policy, over half, 54.9% reported shoulder pain. After the intervention, it dropped by 4% to 50.8%. By contrast, people who were not doing night shift had an increase in their shoulder pain from 51.8 to 59.4. That's a 7.7% increase. And therefore, the difference in difference is a significant minus 10-point reduction in their shoulder pain. This is, in my view, it's almost as good as having a randomized trial, except you didn't randomize. You were observing a natural experiment. We see also reduction in pain reported in the arm by 12.9%, and all upper extremities combined. That includes neck pain, shoulder pain, arm pain, declined by almost 15%. So that's one way in which we can improve being able to make a causal claim. Now, in difference in difference analysis, because we do not begin with randomization, if this was a randomized trial, both the treatment and control group ought to have exactly the same prevalence of musculoskeletal pain. That's the whole point of randomizing the treatment. Because they don't start at the same point, it's very important to establish that the trends in musculoskeletal pain were parallel. They were parallel before the intervention was implemented. And that's the so-called parallel trends assumption, which we can see here. We made the argument that the trends do seem to be parallel for arm and shoulder pain. And so we can at least try to make the argument that we approximated the conditions of a randomized trial. So that's an example of how we might use different methods to try to advance our understanding of health equity. Now, I want to give another example of using these kinds of econometric methods to make a statement about health equity. And I'm going to give a couple of examples of evaluating national policies and legislation. So the first example I want to give is a paper written by Dr. Nami Kim. She's here today with us. I can see her on the screen, actually. And she wrote down several papers while she was studying in my research group. And one question she tackled was whether the 2012 expansion of dental insurance in Korea for the elderly improved their access to dental care. And this was again a difference in difference analysis based on the Korea National Health and Nutritional Examination Survey from the period before the dental insurance expansion and then after the dental insurance expansion. So we have a difference in difference design again. Now, probably all of you know this already, but I learned from Nami that the Korean National Health Insurance covers treatment for dental caries and periodontitis, but has some rather high level of out-of-pocket expenses between 30 to 50%. In addition, dental prosthetic treatment like dentures were not covered by insurance prior to the 2012 legislation, resulting in about 1/3 of older adults reporting unmet needs due to too high of an out-of-pocket expense. And thus, the Korean government in 2012 expanded insurance to cover dental prosthetics, either partial or full dentures, as well as dental implants. And that included up to a 70% reduction in out-of-pocket expenses for all individuals aged 65 years or over, regardless of their level of income. And so Dr. Kim looked at 4 different outcomes: unmet dental needs, denture wearing, dental implants, and number of remaining teeth, all of which were available on the K-NHANES data. So we have data before and after the policy change. So let's look at the difference in difference results. First of all, unmet dental needs. The prevalence of unmet dental need prior to the change in legislation was 28.8% among older people. And after the new policy was passed, to our surprise, there was an increase in unmet dental needs of 8.8%. That's the DID result. So, and it's significant too. So apparently the legislation increased unmet needs, which is not usually what we think of when insurance is expanded. We think of it usually as being good for health equity, but this sort of seemed to increase unmet dental needs. Why? We had a couple of explanations, both from the demand side and the supply side. I think on the demand side, it's possible that this was an effect of rising expectations. When you government expanded insurance coverage, it increased the expectations among eligible people, and that rising expectation also may increase perceived unmet need. Especially when there was persistent out-of-pocket expenses that couldn't be covered by insurance expansion, maybe this may have increased perceived unmet need. For example, if you needed dentures, you went to the dentist, and although it is covered to a better extent than before, it's not quite what you expected, in which case maybe you might report more unmet need. The other explanation, which we can't prove from the supply side, is that maybe there was some degree of provider-induced supply of services. This is a kind of a perverse effect that we often, I should say often, we do see whenever there's insurance expansion. We have to anticipate change in behavior among providers, and so they begin to offer more services. And if the number of services exceeds demand, then you will have an increase in unmet needs. So that's that was one of the unexpected findings of this analysis. On the other hand, we do find effects, the policy effects, in the directions that we wanted to see, which is an increase in the wearing of dentures by 4% and an increase in dental implants by 5% in the older population. So that did the policy managed to achieve that. Now, Dr. Kim, went on to do an additional analysis. So now we're going to move from difference and difference to a triple difference analysis. So what I've been showing you so far is the difference and difference. That is, how much did the outcome change among eligible and non-eligible patients before and after the introduction of the legislation. And the DID here is the difference and difference estimate. Well, the triple difference estimate is derived by adding an additional characteristic, namely the incomes of the patients. Are they low income or high income? And so we're now looking at three kinds of differences. And this is kind of depicted here on a somewhat complicated chart, but it is showing how now we want to know what is the difference in the outcome among eligible low-income patients compared to high-income patients. So we take two sets of double differences, and the difference between these two groups is what we call the triple difference result. This is definitely a form of equity analysis, because it's telling us not just what the average effect is among eligible seniors, it's telling us what's the equity implication in terms of income. And this is what Dr. Kim found, that when we do the triple difference result, the unmet dental need is lower, it was reduced among low-income older adults by 20% relative to high-income adults. So that's a very nice result for equity, because it's telling us that even though on average unmet needs increased, it increased less among low-income adults compared to high-income adults by a factor of 20%. So that's pro-equity, and it's important to know that if we want to evaluate the equity results of a policy. And we don't see similar results for denture wearing and implants, implying that both poor, low-income and high-income older adults had an increase to about the same extent. That's the conclusion. All right, so that's an example. Now, the last thing we found, Dr. Kim found, was that the number of remaining teeth also dropped by about an average of 4 teeth among lower-income older adults compared to higher-income adults. And this may seem a bit surprising, but actually, I think it's a sign that people were receiving treatment. We often, I've seen this before when we looked at the effects of Obamacare in the United States, when President Obama expanded Medicaid insurance. We have also found that the number of remaining teeth among low-income adults dropped. Why? Because all of a sudden they could now access dental care. And when you see a dentist, the first thing that happens is that you lose teeth because they need to be replaced with dentures and caps and so forth. And so this minus 3.8 is not an unexpected effect. It's showing that the policy is working as it should. All right, so that's the first example from dental policy. The next example, the second example I want to show is done by Dr. Huayang Li and Juan Oh, both of whom spent some time in my research group. And this one was also a policy evaluation published in Health Affairs. And it concerns the 2013 expansion of the Korean National Health Insurance Plan, in which, as you probably all know, I wasn't aware of this, the government decided to expand coverage for major causes of health expenditure. So if you have cancer, cardiac disease, cerebrovascular disease, or rare diseases, then all of a sudden the government said we're going to expand coverage for treatment of these conditions. And so this was a health equity analysis of whether the 4 diseases policy could reduce catastrophic health expenditure, impoverishment, and unmet need. So I'm going to call this, we're going to call this policy the 4 diseases policy. And again, they used, Dr. Li used econometric methods, DID, and triple difference analysis to investigate the health equity implications. So as you all know, the South Korean National Health Insurance Scheme, which has been in place since 1989, has been insufficient in scope. That is a range of services covered, as well as in depth. That is the degree of co-payment applied to the coverage of treatments. And that has left many citizens vulnerable to catastrophic spending. For example, during the years 2004 to 2019, around about up to 40% of healthcare expenditure was financed by out-of-pocket expenditure, compared to the OECD average, which is around 14 to 16%. So the Korean government decided during the period 2013 to 17 to expand coverage for the treatment of these major diseases, which were responsible for a high burden of co-payment. And so here are the DID results. First of all, this is showing the change in catastrophic health expenditure according to whether the households were eligible for coverage of the 4 major diseases before and after the introduction of the legislation. Now, a catastrophic health expenditure was defined in the study as when annual health spending for a household was higher than 40% of the total annual household spending net of food expenditure. That's the accepted definition of catastrophic expenditure. So what we see in 2012, before the expansion of coverage, is that the beneficiary households, that is the households who had a family member suffering from one of the 4 major diseases, had much higher probability of suffering catastrophic health expenditure. But we see that after the legislation was passed, on the right-hand side, there is no change in the probability of catastrophic health expenditure for the non-beneficiary households, but a big reduction for the families who had patients suffering from one of the 4 diseases. That's a success story. And so overall, there was an important reduction in catastrophic health expenditure. The next outcome that Dr. Lee looked at was impoverishment, which is defined as when a household is above the poverty line before paying for healthcare, but then falls below the official poverty line because of out-of-pocket health spending. So on the left-hand side, I'm showing you the pattern as it was before the passage of the legislation. You see a gradient in probability of becoming poor, which is higher for the sienna-colored, the right-hand side group. That's the group who has someone suffering from one of the 4 diseases. And you can see that there's a gradient by income. There's a gradient by income. So the lower your income, the higher your probability, and the bigger the gap between beneficiary compared to non-beneficiary households. So what happened after the legislation was passed? The pattern looks like this. Yeah, it's a lot to take in, but what we can see is that at least for low-income households, there was no change in the probability of impoverishment. That's not good. That's not good. So because of that lack of change, there was no overall improvement. And in triple difference analysis, we see that the situation clearly deteriorated for middle-income households. It deteriorated for both non-beneficiary and beneficiary households, but the gap grew even bigger after the legislation. And lastly, for when you look at high-income households, they appeared to have benefited, because you can see the gap between beneficiary and non-beneficiary households has reduced after the legislation. So in summary, we can say through this analysis that the expansion, the 4 diseases policy did not succeed in reducing health inequity. It seemed to benefit the highest income groups the most, and seemed to actually make the situation worse for middle income households. That's important to know from an equity perspective. Lastly, unmet need was surveyed based on a question in the past year: have you ever needed to seek healthcare services, but you've not been able to do it? The left-hand side shows the pattern before the legislation. We see, again, a kind of a gradient. The lower your income, the more likely you are to report unmet need. And interestingly, it's the only group for which beneficiary households reported higher unmet need was in the middle income group. But what happened after the legislation? This is what happened. In general, everyone's level of unmet need decreased. However, there was no overall change in reducing unmet needs. If you sort of collapse all the income groups together, there's no significant difference. And in addition, triple difference analysis suggests a possible benefit for middle income households. You see this middle group here. Prior to the legislation, households with one of the four diseases reported a somewhat higher unmet need, but that reverses after the legislation. So for middle income households, there was benefit, but not for no effect seen for low income or high income households. So in summary, the equity analysis of the four disease policy suggests a mixed picture. The policy did have a positive impact on protecting households from experiencing catastrophic health expenditure, but we see the effect was similar across all income levels, and no evidence favoring households with lower incomes. There was no overall effect on preventing households from falling below the poverty threshold, and possibly even an anti-equity result of favoring high-income households. And lastly, no overall benefit in reducing unmet needs, but maybe a benefit for middle-income households. So this kind of information, I think, is very important for policymakers to understand, what they need to do next in order to achieve a greater health equity through legislation on health insurance policy expansion. All right, so that's the second example. The third example I'm going to give is through conducting cross-national comparative studies. All of us should be doing more cross-national comparative studies to understand how do different country contexts explain health differences between people in different countries. And probably, we understand the most about the USA and England because there have been a series of papers comparing in great detail the health outcomes among similar aged adults in these two countries. And I would like to see more of this done in the East Asia region. So I am going to introduce you to a study done by Shiho Kino, but also the president of your society, Sunan Jung, where we decided to make a comparison between Japan and Korea. We happen to have two nationally representative data where we could do this comparison. Now, as you know, South Korea, Japan are neighboring countries that share many features in common. They're both high economic development countries, high life expectancy, and yet both suffer from high suicide rates. It's very this makes for a kind of a controlled comparison where we can try to understand what might be accounting for it. Can we better understand the social determinants of mental illness in the elderly through cross-national comparative analysis? So, as I said, we had the opportunity to harmonize data, microdata from older individuals from a data set in Japan, as well as the Korean Community Health Survey in Korea. And We conducted multivariable logistic regression analyses to see what were the basis of poor mental health measured by the K6, that's psychological distress, based upon income, comorbidity, and age and gender. So this is what the cross-national comparative work looks like. The left-hand side, men and women in Japan. The right-hand side, men and women in Korea. The vertical axis is the prevalence of depressive symptoms defined by the K6 Kessler-6 score. And we're showing the prevalence of depressive symptoms according to age group. Remember, everyone's over the age of 65 in this study. So the three things which stand out in this comparison. Number one is that overall, there is more psychological distress in Korea, and the older people in Korea compared to Japan. It's quite a bit higher in Korea compared to Japan. The second thing that we notice is that women report more psychological distress than men in each country. So there's a gender inequality and there's a country inequality. And lastly, we see that overall, there is a general pattern of increasing distress with rising age. The older the individual, the higher the level of distress. This is particularly evident among the oldest in Japan, people over 85 years. And the one notable exception, older women in Korea, which seems to run in the opposite direction. Very interesting. And so these are descriptive, but they give us clues about where to go next to understand the sources of mental health inequity in both countries. Next, when we look at quintiles of equivalized income, we see in both countries there is a disparity. There's a gradient in mental distress in Japan and in Korea. However, the interesting thing to note is that the gradients tend to be much more flatter in Japan. There's a much flatter gradient whereas there's a steep gradient in Korea. The higher your income in old age, the lower is your level of psychological distress. So what do we make of this? So this was a descriptive study. It's the beginning of a more detailed analysis to understand the sources of mental health in both countries. But one of the things we can say, based on what we know, is that the social security systems are very different in the two countries. For example, the public expenditure on pensions amounts to only about 2.6% of GDP in Korea, whereas the Japanese spend 5 times as much on old age income security. That might be one source of the difference in the slope of the gradient between the two countries. And we do know that South Korea has a relatively high poverty rate among older Koreans, as reflected in OECD data, where it's estimated that maybe up to half of older Koreans live in relative poverty, indexed by someone whose income is below 50% of the median equivalized income. And so we see this in data where when we look at the income distribution of older adults in both Japan and Korea, the income distribution is right skew, but you can see that the Japanese distribution is more there's less right skew. There's more clustering of low incomes in the Korean situation. So one implication of this is that in order to advance health equity and improve mental health, the countries, especially Korea, needs to invest more in assuring the financial security of older people, older adults, retired people, and older adults. Okay, so last example I want to give is undertaking studies of intersectionality. Intersectionality, as you know, is an approach that recognizes that health is shaped by multidimensional overlapping factors such as social class, race, age, disability status, sexual orientation, immigration status, and geography. So we should not just be looking at social class, but we should also be looking at the intersection of social class with these other characteristics. And as a sort of beginning of a intersectional study, I want to introduce a study conducted by Dr. So-Young Kim and Jong-Hyuk Park, both of whom spent time in my research group. We were interested in whether there are disparities in breast cancer screening according to disability. Now, the number of women eligible for breast cancer screening increased by quite a bit, 4.8 million in 2006 to 6.3 million by 2015 in Korea. And over the same period, because of the wonderful disability registration system you have in Korea, we have also, you have been able to track the prevalence of disability over that time period, which has also increased from 4.5% to 7.2%. So the question that Dr. Kim and Park wanted to ask was, are there disparities in breast cancer screening according to disability status? So you have the ability in Korea to answer that question. And the answer is yes, there are disparities. There's sort of good news and bad news. The good news is that the age-adjusted receipt of mammography improved over time for both groups of women with disability and women without disability. However, as you can see from this trend line, there's been an ever-growing disparity by disability status. So when we look at the, how disability plays into this, the gap has been widening over time. And you have in your disability registry a classification based on the severity of disability, which they were also able to look at. And you can see there's a significant inequity according to severity of disability, particularly for the more severe grades, 4, 5, and 6. You see that the trend line for mammography has remained very low, and the gap is even increasing over time. And so we know one of the things that Dr. Kim and Park described was that the largest improvement in screening rates have been observed for women with hearing and vision loss disability, physical disability, and epilepsy. Nonetheless, we see the smallest improvements for women with mental disorder and intellectual disability. That's telling us from a health equity perspective, which are the groups that require more attention. And this, as I said, is the beginning of an intersectional analysis. We should research the intersectionality of disability with factors like social class, geography, and sexual orientation. You have the data in Korea to be able to begin to do this. And I think that is an important contribution to how we can deepen our understanding of health equity. So in conclusion, social epidemiology in Korea, I've given a small window based on the research of people I happen to know, but research in Korea continues to make cutting-edge contributions to studies of health inequity. I think future directions for research that your members of your society might consider would include ongoing evaluation of policies and interventions, quasi-experiments, cross-national comparative work, and explorations of intersectionality. I mean, as a kind of a journal editor of social science and medicine, I think these are the very important areas in which advances are being made to deepen our understanding of health inequity. All right, so to end, I just want to thank all of my research collaborators and colleagues. This is what my research group looked like back a few years ago when Dr. Jang was still with us, and we had a visit by Sir Michael Marmot to our lab, and we made some presentations. So you can see my research lab members. There's Dr. Youngju Kim, there's your president, Seung-Han Jung, and there is Huayang Li, whose study of the 4 diseases policy I introduced, and Shiho Kino, she's Japanese, but she worked with Dr. Zhang to do the cross-cultural comparative analysis. Here's another nice dinner we had. If you come to my lab, we have nice dinners. And we in attendance that day were Dr. Juan Oh, who worked with Dr. Lee to do the 4 diseases analysis. There's Professor Jong-hyuk Park and So-Yeon Kim. I think I just saw Dr. So-Yeon Kim earlier. They are the scholars who have been studying disability as an axis of health inequality. The earlier study on dental insurance was done by Dr. Nami Kim. I think she's here today, and Hae-Yoon Lee. I think I saw Hae-Yoon Lee before as well. She's the scholar who did the study on the quasi-experiment of night shift in relation to musculoskeletal pain. So thank you very much. I've come right in on time, and we have 15 minutes for questions.
Thank you very much for your great lecture. And that looks very delicious.
Yes, yes. I'm sorry you weren't there.
Yeah. Through the research cases with the Korean scholars, you showed us the possibility of policy evaluation and policy assessment in the field of health equity, which is the area we have focused on. So I'm sure that many participants have questions to you. Now we're going to have a Q&A session, about 50 minutes. So if you any questions, please use raise hand function or turn on the microphone and speak directly. Or if you have trouble using the microphone, please leave a question in the chat room.
I should mention before anybody raises their hand and asks the question that, if you have questions about those individual studies, the authors are in the room, so you can direct it to those professors. And all mistakes that I made are mine and not the authors.
Okay. Any questions?
Yes.
Yes.
Okay. Yes.
Yes.
Hi, Dr. Kawachi. I'm Sunji Jung. I was a former URB fellow, and I met you in Harvard. And right now I'm back in the Pop Center. So it's like the Pop Center around me in Harvard.
You're local. Nice to meet you.
Yeah, local. Nice to meet you. Actually, I'm not a member of this community, but I just want to scoop in to listen to your wonderful talk about this. And I had 2 questions about this. One is the thing I saw from your paper, the healthy but not happy paper, that the Korean women, when they got aged, it was really interesting to see that their depression got lower. So it's like any explanation for that? And I'm very curious about, it's like a social norm or like the gender roles they are getting exposed to compared to Japanese women. But I heard that Japan is also have a high standard of the gender roles, right? So what is the difference between these 2 populations, and that I'm wondering of? And then number 2, and number 2 is the cancer. It's like I'm also digging into the problem with the schizophrenia and also the incidence of breast cancer in women, and we are getting a really kind of inverse result. Like the women who have schizophrenia have lower incidence of breast cancer, which we couldn't make it because we, biologically, we say, well, if we have kind of the treatment, then we will just increase the risk, not lower the risk of breast cancer, but it was very increased. I mean, it was reversed. So I think we have the same context in this space, I think. So can you elaborate more about this? Thank you.
So 2 excellent questions. You've spoken like a true sociologist, that you would want to look at focus on the status of women's mental health as they reach older age. So We don't know the answer, but because Dr. Zhang is the one of the lead authors of that paper, I'm going to ask her to comment on this as well. But I do think that it is the sort of somewhat protective, association we saw with older ages in Korea. That the mental distress declines as you grow, advance more and more in age. I think part of that may be a kind of a birth cohort effect, that if you're in the 85 plus, 75 plus age range in Korea, maybe you are still of that generation where you can expect to have, good, be looked after by members of your family. Probably more of those women experienced living in a multi-generational household where once you attain a certain age, you can rely on your adult children to look after you, and that the older women in that sample were benefiting from that kind of arrangement, whereas it's becoming less common for more recent generations of women as they age. And I don't know. I think we need to dig into why we don't see the same kind of thing for Japan. In Japan, overall, there's lower prevalence of distress, which I think is related to the higher financial security from the social, national pensions system. But it's a mystery that I think cross-national comparisons like this open up in a way, isn't it? Dr. Zhang.
Yes. Maybe many explanation can possible here. The story of the age trend in the Korean women's depressive symptom, and most of the oldest elderly women, if they have a depression and other disability, and they're more tempted to go to the long-term care institute compared to Japanese women. So that is a community health survey data set. That means all of the participants are community dwelling people. So that is one of my assumption, that the depressive symptom prevalence is lower in the oldest old women, and because they are more likely to be healthier than the younger old elderly women.
That's interesting. So that's you're suggesting it's they're missing from the survey because they've been institutionalized.
Yes.
I hadn't thought about that. That's interesting. Yeah.
The other story can be possible because the marital status effect. Yes, that there must be without in the oldest or the elderly women.
Yes.
They escape from the many caregiver roles.
Yes. Did everyone understand that? That's a sort of a feminist interpretation of women being liberated from many caregiving roles. Great. So the other question about mental illness, schizophrenia, and breast cancer, I wasn't aware of that. So you're suggesting that in your data, women with schizophrenia seem to have lower incidence of breast cancer.
Right, we use the national health insurance data, and then that was only very administrative purpose. So we will see the true cases, but in the cases that you go to hospital, you get diagnosed, and then those whole processes are just limited to the people who aren't getting the schizophrenia. And I was just wondering about what is true beyond that.
Well, so this is pure speculation, but obviously reproductive factors are the main risk factors for breast cancer. It's possible that if you do not have children, or you have children less early and so forth, that you would be at increased risk for breast cancer. So I'm not sure how to explain that, what you're finding. The study I introduced was about access to screening and there's a second part related to survival. And clearly, those data show that there is a disparity according to mental illness disability. So yeah, that if there's a lower incidence, but then less, access to screening and lower prognosis, I think that's
Yes, so we interpret it as a lower access, like not the true cases, but the lower access to medical diagnosis. So it could be like this very same context with the screening, I think.
That's very interesting. I saw Dr. So-Young Kim is here. Did you have a comment on that?
Yeah, it could be explained by that different viewpoint. Lower access contribute to the lower incidence of breast cancer, I think, and also breast cancer could be happen in lower incidence rate of breast cancer could be happening in schizophrenia women, but lower accessibility in women with disability is a different thing in this view.
Yeah, so if this is due to mammography detection of breast cancer, then you're talking about kind of it's a sort of like a lead time bias, isn't it? You're saying that women who don't have mental illness are having their tumors detected earlier, and the incidence appears higher. But eventually, they should catch up because of when the lead time expires, and so if we look at mortality, we should see the expected disparity. Do you see what I'm saying? So the incidence might be artificially low because of the screening lead time, but then I imagine that eventually those cases of cancer would catch up, and I imagine we would see the disparity in the expected direction, higher mortality for women who did not receive mammography. That would be worth checking.
Yes, that's a really good point, I think. We actually saw the entire lifespan of the women, so maybe the lead time would be checked, and we will check it properly. Thank you so much.
Yeah, great.
네, 또 질문. Any question? 네, 새롬 김.
Hello, my name is Serum Kim, and I'm studying at the Public Health Graduate School of Public Health. I studied health policy, and I'm really nice to meet you. So I think there is not much time left, but I want to ask you one big question because I have read a lot of your articles, and it is also same for Korea that more and more people are studying health equity, and more people are getting their interest in the social determinants of health. But there are a lot of evidence indicating that that people who are vulnerable, but the policy is not changing. So in Korea, we often say that the policy is not evidence-based, but evidence is based on policy. It's kind of sarcastic saying, but according to my understanding in US, I think you have the same situation around you because you are this really big person and you might have the opportunity to get involved in the policy. But as I know, US have the whole different problem from Korea, but you also have this whole lot of health equity problems. So what do you recommend for this community of academy who are equity have to keep looking forward in case of changing the policy itself, not just looking at it and putting it?
Yes, yeah, that's a great question. So that's the same dilemma I have struggled with for 40 years, isn't it? How come I produce evidence and and we don't see change. Like, one of my big interests is income redistribution, and every time I publish on income redistribution, the policymakers do the opposite. They make it even more unequal. But I think I would say that the reason why we keep doing this is because it is very important for researchers to produce the evidence, to be prepared when the window of opportunity presents itself. If government were to change and a more progressive administration were to become elected, it's important for us to have the policy ready and the evidence ready in order to guide policy making. And I think, I feel that it's not all going in, not everything is going in the wrong direction. There are, times when things move in a equitable direction. For example, you mentioned, U.S. is not well known for health equity, but many people don't realize that our child poverty rates have dropped by half. It's dropped by 50% in the last few years because of policies like earned income tax credit expansion and child tax credits. And these were not widely advertised at the time, and they were kind of brought in partly because of COVID and other things. But when we look, suddenly we notice that we've cut child poverty by half. That's a huge health equity advance. And I think these things would not have happened as quickly if the evidence wasn't there that for example, earned income tax credit can improve children's health and promote health equity. So my advice is, don't feel hopeless and despondent. There will, come a time when the evidence we prepare will be relevant and important for, policymakers to guide their decision.
Okay, we have one question more in the chat room, but I would like to ask you differently, but the same question. You conduct research not only with Korean scholars, but also with many international scholars from many countries. So how important do you think the international network among researchers is for the health equity research?
Yes, yeah, I think that's incredibly important, isn't it? It's incredibly important.
I'm sorry, but I would like to interrupt you. The moderator have the wrong interpretation of my question. I'm sorry. I'm more interested in the influx of the researchers from low and middle income countries with the publicly funded and administered data to the US. So basically they are contributing to the publication list to you, to the Harvard University. So what do you think that, what is the reason and how do you pay back to the countries who are offering you the opportunities and data and all the intelligent people? So what is your view?
Yeah, my view is twofold. Obviously, we do want to offer training for people who come from all over the world. It's not just Korea, but as Dr. Zhang just said, we have many collaborators from across the world. They come to Harvard not just to train personally under me, but to take courses and network and meet with other researchers. And the way we pay back is, clearly the researchers go back to the countries and they contribute to training their students and to contribute to the national discourse on health equity. I think, I'm a big believer in international cooperation, and obviously I don't do this to increase my publications. I don't need any more publications, and it's very, therefore, what we're doing here is, to try to increase the analytical capacity of global researchers to come and take back, what they learned, and hopefully to build the, capacity to conduct health equity research in their respective countries. That's how I consider the task that I'm involved in.
Okay. we have another question in chat room, but it's time to finish because it's too late for us. And Professor Kawachi have a schedule today. So I'd like to thank you, Professor Ichiro Kawachi, once again for giving us a lecture today. Today's seminar ends with this. Thank you, everybody,
Great.
for your participation.
Thank you very much. Thank you for your questions.
Okay, have a good
Okay.
day and have a good night.
Nice to see you.
Nice to see you.
Good night, everyone.